Hello, everyone, and welcome to today's webinar, Strategies for Lot-to-Lot Evaluations of Autoantibody Serology Assays. I am Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Bio-Rad Laboratories. To learn more, visit www.bio-rad.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Also, if you experience any technical issues, you can utilize this Q&A box and we will assist you directly. I'd like to now welcome our speaker, Dr. Melissa Snyder, Co-Director, Antibody Immunology Laboratory at the Mayo Clinic. Dr. Snyder, you may now begin your presentation.
Well, thank you so much for that introduction. So now let's jump into our discussion of strategies for lot-to-lot evaluations as it applies to autoantibody serology testing. To begin, I'll just share some disclosures with you. I have served as on an advisory committee for Warfarin and AliveDx, both of whom specialize in autoantibody serology testing, but I won't be sharing any off-label usages of laboratory testing today. So hopefully you've had a chance to see this, but just to share with you the learning objectives for this webinar. After this presentation, I'm hoping that you'll be able to describe the regulatory requirements that are out there for lot-to-lot evaluations, specifically as they apply to autoantibody serology testing. Hopefully you'll be able to identify parameters as well as acceptance criteria that you could include as part of your lot-to-lot evaluation program, again, for autoantibody serology testing. And then lastly, should be able to assess lot-to-lot evaluation data, again, specifically as it applies to autoantibody serology testing. So as we begin our discussion today, I thought it would be good just to get us all on the same page and really make sure we understand what we're talking about when we say, what is a lot-to-lot evaluation? Well, in my mind, a lot-to-lot evaluation is a protocol in which you assess the performance of a new assay reagent lot by comparing it with the performance of an existing or current lot of reagents. So that's what a lot-to-lot evaluation is, but really what are we trying to do with a lot-to-lot evaluation? Well, in my mind, the goal of a lot-to-lot evaluation is to make sure that your clinical testing has long-term analytical and clinical stability in your assay kits and reagents. Why do we have to do this? What could impact performance of a new reagent lot? And there are multiple things I think that could occur. You could see changes in materials that could impact performance, changes in calibration. There could be instability of reagents that causes shifts in performance over time. You could also see damage that occurs to the reagents even during shipment or storage. And the last point I want to make here before we leave this slide is that the lot-to-lot evaluations that we'll be discussing today is applicable for both FDA cleared tests and laboratory developed tests. With FDA cleared assays, we're often thinking about doing lot-to-lot evaluations of kits, where with laboratory developed tests, we're often thinking about lot-to-lot evaluations of individual reagents. However, the goal is the same, really, is to make sure that regardless of what type of assay you're dealing with, that you have long-term stability of that testing over time. So we've kind of scratched the surface and kind of started to understand why lot-to-lot evaluations are important. We really want to maintain that long-term assay consistency. But the other thing we have to remember is that lot-to-lot evaluations are a regulatory requirement for clinical laboratories. The one regulatory requirement I thought we could take a look at is a checklist item that occurs within the College of American Pathologists, or CAP, All Common Checklists. And this checklist item is COM.30450. And this deals with new reagent lot and shipment confirmation of acceptability for non-wave tests. So what this checklist item deals with and is requiring is that new reagent lots are checked against previous reagent lots or with a suitable reference material either before or concurrently with being placed into service. And the checklist item highlights that this applies to reagents that are part of a chemical or biological reaction that is used to measure the analyte, and not really applicable to inert materials. And inert materials could be something like water, it could be a saline solution, maybe it is the plate that you're using. So this checklist item doesn't necessarily apply to those materials, but rather reagents that are generating a signal that is used to then measure the analyte of interest. I think there are a few important aspects of this checklist item to highlight. And again, we're going to be focusing on how this is relevant for autoantibody serology testing and a lot of evaluations. So first of all, the checklist item does differentiate between qualitative and quantitative methods. Now, for those of us who do a lot of work in autoantibody serology testing, I think we'd all appreciate that the testing that we deal with is semi-quantitative. So it's a little bit of kind of, I don't want to say out of scope of this checklist item, but there are definitely some differences about semi-quantitative testing that makes it difficult to lump it in either a qualitative or a quantitative bucket. So we just have to keep in mind that this checklist item is really focusing on qualitative and quantitative methods, and we have to think about how that applies to testing that we would define as semi-quantitative. The checklist item does deal with kind of the rigor of the evaluation, and specifically they state that the protocol that the laboratory is doing has to at least meet the minimal requirements as established by the manufacturer. So oftentimes we'd be thinking about certificate of analyses and whether or not the performance of the new lot of reagent meets those criteria as established within that certificate of analysis. But beyond that, most manufacturers don't establish protocols for lot evaluation. So I think really that's what this checklist item is dealing with, at least again, as it applies to autoantibody serology testing. The checklist item does focus quite a bit on what kind of materials may be used for evaluation of a lot-to-lot. They highlight the use of patient specimens. They indicate QC material could be used, such as what is provided by the manufacturer with the kit. They suggest the use of proficiency testing material as well, or QC material that may have a peer group mean that may have been established via another mechanism. However, they do state that patient specimens are really the optimal specimen to be using when you do a lot-to-lot evaluation to control for those matrix effects. And I think for autoantibody serology testing, this is particularly important with the heterogeneity that we see with autoantibodies and how they react to antigens and how they react differently to different antigens and different epitopes. By using patient specimens, you're really getting a broader sense of how one lot compares to another, taking into account that heterogeneity. Now, there are some important items not specified within the checklist item, which we will talk about as we progress through this webinar. But I do think it's important to understand what this CAP checklist item does not specify. First of all, they don't specify anything about sample characteristics. And when we're thinking about autoantibody serology testing, we often think of samples in the context of positive, negative, reactive, non-reactive. And so when we think about doing a lot-to-lot evaluation and having that protocol, how do we define which particular samples, what types of samples we should be using? In addition to that, the number of samples is not identified within the CAP checklist item, and in fact, it specifically states that the laboratory may determine the number of specimens tested. So that would be up to you and resources available in your laboratory and how many samples you would be able to collect and test. Then the evaluation protocol. Again, the CAP checklist item doesn't identify what parameters you should include in your lot-to-lot evaluation. As we progress through the webinar, I'm going to be sharing with you the parameters that we use in our laboratory, kind of as an example. But again, this is up to the laboratory for when they establish their protocol. And then lastly, acceptability criteria. So this is criteria that you would predefine before you would do your lot-to-lot evaluation as part of your protocol. And this would determine whether or not, if your evaluation meets that acceptability criteria, you would deem your lot-to-lot to be acceptable. If it doesn't meet that criteria, then you would have to determine next steps in terms of investigation and what you would do in the case of a failure. Now, in addition to these regulatory requirements, there are some guidelines which have been published as well. And the one that I'll discuss a little bit today is a guideline that was published by the Clinical and Laboratory Standards Institute, or CLSI. And the guideline that specifically deals with lot evaluation is EP26, or User Evaluation of Acceptability of a Reagent Lot Change. And with this guideline, the purpose of the guideline is to help you develop a statistically valid protocol for lot-to-lot evaluations. And they do really have a lot of really good information within this guideline. And I tried to pull out just a few important pieces that I thought were relevant, again, specifically as we think about autoantibody serology testing. So some of the general considerations that this guideline suggests when a laboratory is putting together a lot evaluation protocol. First of all, the guideline acknowledges that lot evaluations can be very time consuming, and the protocol that a laboratory defines needs to take into account how frequency you're going to be doing lot-to-lot changes, and what resources you have available to you in terms of instruments, personnel, patient samples. All of those are going to play into how you design a specific lot evaluation protocol for your laboratory as well as for your specific testing. The guidelines, give you some ideas on what you should be thinking about when you put a protocol together. And they highlight that the protocol design should really make sure that you are allowing for detection of reagent performance changes that could impact clinical utility, while at the same time minimizing chances that an acceptable lot is rejected. You don't want to be rejecting every other lot that you get because your criteria are maybe too stringent. So just have to think about that. How do you design a protocol that allows you to detect a change that's clinically important, but doesn't put you at risk of rejecting lots that in reality are acceptable from a clinical performance standpoint? And similar to the CAP checklist, this guideline specifically says that it is only intended for quantitative methods and not for assays that are qualitative or semi-quantitative. So at this point, you might be thinking, well, since autoantibody serology testing is semi-quantitative, then these guidelines aren't going to be much use to us. And it is true that there's a lot of information in there that is not going to be directly applicable for lot-to-lot testing for autoantibody serology assays. However, I still think there's a lot of good information for us to think about that you can apply in principle to your lot evaluation protocols. So some of the specific protocol suggestions that are included within these guidelines, it does again stress the use of patient samples, focusing again on the fact that this takes into account matrix effects. And the guidelines specifically state that QC materials, as well as similar materials like proficiency testing samples, should not be used alone to evaluate lot-to-lot changes in reagent performance. And then the guidelines give you a few suggestions for determining your protocol parameters. You need to make sure you're considering the analytical performance of your assay as well as the clinical utility of that testing. That's going to help you identify which parameters are going to be relevant for evaluating new lots in your laboratory. You should be thinking about the number of samples that you're going to be testing as well as those characteristics. And when we think of characteristics, we're often thinking of, again, of that positive versus negative and how many of each of those types of samples would we want to include in a lot evaluation. And then defining acceptable criteria for variation between the lots. So now that we've reviewed the guidelines and regulatory requirements, I'd like to go into sharing some approaches and examples of lot-to-lot evaluation protocols for autoantibody assays that we have in our laboratory. We'll look at how we have designed our evaluation protocols, the parameters that we include for evaluation, and then the acceptability criteria that we've defined. And we're not going to be able to cover every single method today. So the methods that I've tried to focus on for the rest of the webinar will be the indirect immunofluorescence testing, enzyme immunoassay, and multiplex immunoassay. But before we get into the specifics of each individual method, I just thought I'd share a little bit of a flow chart on how we approach lot-to-lot evaluations. So we receive a new reagent lot in the laboratory, and when that happens, we begin collecting samples, and we collect samples from clinically ordered patient specimens that are in the laboratory, and we collect those specimens based on the protocol that we have for each individual method or assay. So we know how many samples in total we're going to collect, how many positive, how many negative samples. And those samples are collected and then they're tested. And we do test the samples on the current lot again. So we test them as a cohort of samples on the current lot. And then usually within 1 day, we would test the samples on the new lot. The data that we collect is then entered into a spreadsheet, and that data is reviewed by our management team. If the management team reviews that data and finds that all of the parameters meet our acceptance criteria, then we are pretty much done. We put the lot into clinical testing, make it available for clinical testing. If the management team finds that there is some parameter that does not meet our acceptance criteria, that's going to trigger an investigation. And sometimes these investigations are quick, sometimes they are more prolonged. It just depends on the nature of the parameters not meeting the acceptance criteria, how far out of acceptance criteria we are. But after the investigation, if the management team finds that the lot truly is acceptable, then they would put that into, make it available for clinical testing. If, however, after the investigation, the laboratory feels that this is just not meeting our acceptance criteria, we are concerned that there would be a significant shift in the performance of this lot, specifically related to clinical utility, then that lot would be rejected. And we would likely, certainly by this point, be working with the manufacturer to understand if another lot was available, what could we do in order to maintain testing in the lab, acknowledging though that the lot that we had received just is not going to work for the testing that we're offering. So now that we've gone through that general flow chart, let's look at indirect immunofluorescence specifically. So with IFA, we focus a lot on sample selection, and that's really the crux of our lot-to-lot evaluation. Sometimes we do include controls, but in the context of IFA, patient samples are really key. And the number of characteristics of the samples depend on the specifics of the assay. Do we report a pattern with this immunofluorescence testing? Do we report a titer? All of that will play into how many samples we collect and what the characteristics of those samples are. What are some of the parameters for evaluation that we could be looking at? We could be looking at positive, negative, qualitative concordance. If it's reactive on one lot, is it reactive on the other? We could be looking for concordance in terms of pattern identification if we do report a pattern. And for titer, we would want to know, if we're going to define concordance for a titer, what's the dilution range that we would find acceptable to allow for that definition of concordant results. Now, when I was putting this webinar together, I thought, well, I'll just kind of talk about all the indirect immunofluorescence testing that we do in the laboratory. But after I started really digging into the details of all of our protocols, I really started to appreciate that each indirect immunofluorescence assay that we offer in the lab really has kind of a unique protocol for the lot-to-lot evaluation. And I think that really just reflects the fact that we report these assays differently, and that leads to differences in the lot evaluation protocols. So the lot evaluation protocol that I'll share with you today is specific for our ANA by Hep2 immunofluorescence. So, as I said, sample cohort and defining the samples are very important when we think about lot evaluation protocols for our ANA testing. For our ANA testing, we define a sample cohort of at least 12 positive samples and at least 4 negative samples. And we also have some considerations that we try to take into account when we're selecting those samples. First of all, we want to select samples that represent the nuclear and cytoplasmic patterns that we report on a routine basis. That's the first thing. And the second thing is that we do try to avoid positive samples with a greater than titer. Now, that's not always feasible, and the caveat that we put in with these considerations is that this is always based on sample availability, but these are the kinds of things that we're optimally that we're trying to do in terms of identifying a sample set for this lot evaluation protocol. We focus on patient concordance for our lot evaluation on our ANA testing. We define an acceptability criteria of greater than 85% concordance. But we need to be a little bit more detailed here, right? Because we're reporting patterns, we're reporting titers, we have cytoplasmic, we have nuclear patterns. So we need to really understand what we mean by concordant. For samples that are negative, we're looking at strictly qualitative concordance. If the sample was negative on our current lot, it should be negative on our new lot. For positive samples that have a nuclear pattern, we're looking for pattern identification as being consistent to define concordance, as well as plus or minus 1 titer between the current lot and the new lot. That would also qualify as being a concordant result. For cytoplasmic patterns, we don't report a titer for cytoplasmic, but we do report the pattern. And so if we include cytoplasmic patterns within the lot evaluation, we have to show that the cytoplasmic pattern is consistent, again, to define concordance. So what I'll show you now is some data from a lot-to-lot evaluation for our ANA by Hep2 cells. We had a total of 18 specimens on this particular lot evaluation. And I'm not going to go through this in detail, except to highlight the fact that if you look at the negative samples, they did agree across the lot, so we would define that as 100% concordance on negative samples. If you look at the pattern agreement between the current lot and the new lot, you would also see that each sample had the same pattern identified. So that would give us 100% concordance on those positive pattern concordance data. And then if you look at the titers, you'll also find that we did not have a sample that deviated by more than 1 dilution in terms of the identified titer. So we would define that also at 100%. So overall, this lot-to-lot showed a qualitative concordance of 100%. If you remember, our criteria is greater than 85%. So we would deem this new lot to be acceptable, and we would put this into use for clinical testing. So I hope that gave you an idea of how we approach lot-to-lot evaluations for our indirect immunofluorescence. Now I want to move into enzyme immunoassay and multiplex immunoassays. So with EIA and MIA samples, our selection is also very important. Here, though, we have a little bit more flexibility, and we include a few other sample types as well. We do look at the kit components when we're doing our lot evaluation protocol, and these would be standards and the kit controls. We also use an in-house control. Now, this is a control that we prepare in our laboratory. It's a pool of patient samples, and we use this for routine assay QC, but we also include it in our lot evaluation protocol because this really, the thing I like about this, well, two things I like about this. One is that it's a patient matrix, so it's a control, but it's a patient matrix, so it's treated just like a patient sample. And number two, because we use these in-house controls for rather extended periods of time, we usually find that the in-house controls go across multiple lots. And so we have a little bit more of traceability across multiple lots as opposed to a single control that is just looking at a comparison from one single lot to another lot. And then we have our patient samples. And again, we often think for our EIAs and MIAs in the context of how many negative and how many positive samples do we want to have for our lot evaluation. So let's just look at the sample cohort to begin with. So this is our patient sample and how we think about that. So for the enzyme immunoassays, we target a minimum of 14 positive samples and 6 negative samples. Some of the considerations, we do put the caveat in there that sometimes we're not able to find that many positive samples, and it does depend on availability. The sample should span the AMR as much as possible, again, based on availability. We try to avoid positive samples with a greater than value, negative samples with a less than value. All of these things are things that we think about as we're collecting the samples, but acknowledging that sometimes meeting all these criteria are difficult. When we go to the multiplex immunoassay, now we're just targeting to collect 30 patient samples. So why don't we differentiate between the positive and negative samples on multiplex immunoassay? Well, I'll get to that in just a minute. First of all, with the patient samples, again, we want to make sure the sample values are spanning the AMR. But here's why we this is why we just say we're going to look for 30 patient samples, because when we assess these samples, we're assessing for multiple antigen-specific autoantibodies in the same assay. And so if we have the majority of our samples being positive for at least one analyte in that test, they are likely going to be negative for multiple analytes also within that assay. And so by having those 30 patient samples, by default, we end up with a mixture of positive reactivity and negative reactivity across the various antigens. So that's why we don't identify specifically having negative samples, but that's just within that 30 patient sample cohort. Similar to the EIA, we're looking to try to avoid samples with greater than values, avoid negative samples with less than values. But again, these are all determined by what is available to us from our clinical testing samples. So now that we have identified what samples we're using for our evaluation, now let's talk about the parameters that we use. And I'm going to start with the EIA first. So here are those samples that we talked about, our kit standards, our kit controls, that in-house control, and then the patient samples. When we look at the standards, what we're really thinking about here is the raw signal. What is that raw signal that we're detecting for the standards? And in this case, we're really looking to what's provided by the manufacturer to determine if the lot is performing acceptably. So we're not comparing the raw signal of the standards to the previous lot, but rather looking at the certificate of analysis from the manufacturer. The kit control, we are looking at a calculated value here, not the raw signal. But again, we're not comparing it to the previous lot, but rather looking to make sure that the kit control is acceptable based on information provided by the manufacturer. For the in-house control, we are looking at a calculated value. And here, because this is a sample that we prepare in the laboratory, we have a few options as to what parameter or how we could use this. We could look at qualitative concordance. Is it reactive on one assay and reactive on one lot and reactive on our new lot? We could also look at percent difference. What is the semi-quantitative result we generate, and what's the difference between those values across the lots? With our patient samples, we're looking at the calculated value that we generate. Again, a few options for parameters that we could include. We could be looking at qualitative concordance agreement across the lots. We could be looking at percent difference, either on an individual sample basis or across all the samples, kind of an average percent difference. Or we could take a linear regression approach where we look at slope and or the correlation coefficient. So these are ideas as far as parameters that you could include. Now I'm going to show you specifically what we do in our laboratory. So again, here are the samples that we're talking about, the standards, kit control, in-house, and the patient samples. For the standards, we talked about looking at that raw value and whether it's acceptable based on the COA, and that's what we do in our laboratory. We're simply looking at that COA to determine acceptability of that standard and that in that new lot. For the kit control, we look at that calculated value, again, comparing to what's in the certificate of analysis, and that's the acceptance criteria that we use. For the in-house control, we talked about possibly using qualitative concordance. We don't have that as part of our acceptance criteria. Instead, we do look at percent difference, and we define acceptability as less than 25% difference between the previous lot, the current lot, and the new lot under evaluation. For patient samples, looking at those calculated values, we do look at qualitative concordance for our patient samples, and we target greater than 85% for that acceptability. For percent difference, we actually don't have that as one of our acceptance criteria. It's not something that we evaluate. Instead, we evaluate for linear regression, looking for a slope between 0.8 and 1.2, and our correlation coefficient, R squared, greater than or equal to 0.85. So in a little bit, I'll show you some examples of this, but this just gives you an idea of the type of acceptance criteria that we use and the parameters that we include for our lot evaluation protocols for our enzyme immunoassays. Now I'm going to show you what we do for our multiplex immunoassay. Here are the samples that we have. For standards, we're looking at raw signal, comparing to the certificate of analysis. That's what we would do here. For the kit control, we look at that calculated value. Here we do look at qualitative concordance between the lots, and we're looking at a more than 90% qualitative concordance. In this case, you also could theoretically look at the percent difference, but that's not something we do in our laboratory. For the in-house control, we do look at the calculated value here. We also evaluate for qualitative concordance. This is going to be looking at the in-house control across the various analytes that are present within that assay. So that's why we have that greater than 90% qualitative concordance, and we don't look at percent difference for the in-house control on the multiplex immunoassay. For patient samples, we have the same options. We could look at qualitative concordance, which is what we do, and we have this set at minimum 90% on average across the analytes that are present within that multiplex immunoassay. For average percent difference, we do look at that in the context of our patient samples, and we look at having a less than 25% for our acceptance criteria. And then linear regression, we actually don't include as part of our acceptance criteria for our lot evaluation. So at this point, you might be asking, well, why do you have different lot-to-lot protocols between multiplex immunoassay and the EIA methods? And the reason we have these differences in the protocols is because we actually, over the last year or so, have been working through a project for improvements in our lot-to-lot evaluation process. And in doing that, we've evaluated the enzyme immunoassay process. We have completed that project. We have implemented changes to our lot-to-lot evaluation process, so that's why that looks different. The MIA still is more a reflection of what we had done historically, and the improvements that we're making to that process are still ongoing. And so that's why it's just kind of, I wanted to show you kind of how our lot-to-lot protocol has evolved over time. And as with most clinical laboratories and most of our processes, we're always looking to improve how we do things in the laboratory. And this is just a good example of how we have looked at our lot-to-lot evaluation process and tried to make improvements, again, simplifying the process while still allowing us to have a robust evaluation for new lots when they come into our lab. So moving forward, when I show you some examples of lot-to-lot data, I'm going to be focusing on the enzyme immunoassays since this is our newer process. We'll be looking at the sample selection. We're going to discuss data from all the different types of samples that we look at, and then also discuss whether or not the lot evaluation that we did ended up to be acceptable for clinical testing. So I'm going to walk you through 3 examples. But before we get into those examples, just wanted to remind you of the parameters that we're going to be looking at. We're going to look at our standards and our kit controls, comparing that to the certificate of analysis from the manufacturer. For our in-house control, we're looking at percent difference between the current lot and the new lot at less than 25%. And then for patient samples, we will be considering both qualitative concordance and the semi-quantitative comparison evaluated using linear regression. And we have that slope and correlation coefficient acceptance criteria. So here's our first example, and I'm going to try to walk you through this. Each one's going to look pretty similar in terms of the how I've set the data up. So I hope hope you'll be able to follow along with me. So this is an enzyme immunoassay lot-to-lot evaluation that we did for autoantibody serology testing. We evaluated the blank OD value, the current lot results not applicable. We look at the new lot. Does it fall within the acceptance criteria from the manufacturer? And it does. So we check this box as saying it meets our acceptance criteria. For standard 1, we look at the OD value on the new lot only. This is the acceptance criteria from the manufacturer. We meet that criteria, so we are acceptable there. With the kit positive, again, this is from the manufacturer, the calculated value. We look at the result on the new lot, compare it to what is defined as acceptable based on the package insert. Again, we find that to also meet the criteria. If we look at the kit negative control on the new lot, compare it to the acceptable criteria in the package insert, we also find that that meets the acceptance criteria as well. We then move on to our in-house control. Here we're looking at the calculated value. Here we are comparing current lot to new lot. So here's the current lot compared to new lot. But our acceptance criteria is based on that percent CV. Here we have a 9% CV. Our acceptance criteria is less than 25%. So this also meets our criteria. So far, the standards from the kit, the controls from the kit, our in-house control all meet criteria. Now we move on to our patient samples. So here is the sample set that we use for this particular evaluation, and I've tried to color code these to make it a little easier to see. Green are samples that fall into the negative range. Yellow is the weak positive or borderline range, and then samples highlighted in red are the positive. Samples fall into positive range. And hopefully you can appreciate between the current lot and the new lot that we see a lot of alignment of color, indicating that we probably have pretty good qualitative concordance between the current lot and the new lot. We take that one step further and look by linear regression, and here is that data showing you the solid line would be a slope of 1. The dashed lines are the plus minus 20% that we allow for the slope. You can see that the red line, which is fitting all the patient specimens, is falling within that 20% criteria, and we have an R squared of 0.959. And so when we put that together with our previous data, if we look in concordance, we ended up with a 95% qualitative concordance, meets our acceptance criteria, so we're good there. Our slope also falls within that 0.8 to 1.2, so we are good there. And our R squared also meets that criteria of greater than 0.85. So this would be a lot that we would find acceptable with really very little questioning. So that's the first example I wanted to share with you. Here's the next example. So this is a different enzyme immunoassay for a different antigen-specific autoantibody, but we're going to walk through the same type of data. So we start by looking at the blank OD. On the new lot, it meets the acceptance criteria that's within the package insert, so we're good there. Standard 1, also looking at that value on the new lot. It meets the criteria from the manufacturer, so we're good there. Kit positive, we're looking at the calculated value. We get a 54.2. That does fall within the range established by the manufacturer. So again, we meet that criteria. The kit negative, looking on the new lot, it does meet the acceptance criteria, so also acceptable there. Then we move to the in-house control. We're looking at the calculated value, comparing the current lot to the new lot. Looks to be very consistent. When we calculate that percent CV, it's very low, certainly meets our criteria of less than 25%. So that's also acceptable. So far so good on this lot-to-lot evaluation. When we move to our patient sample comparison, again, looking for color alignment across the current lot to the new lot, we see, again, pretty good alignment, green to green, yellow to yellow, red to red, not too bad. When we look at the linear regression, we may start to see a little bit of something we would question. We see that that red line that's fitting to the specimens is falling a little bit outside our dashed line, indicating that we may be out on our slope. And if we pull this data into our last table here, we find that the concordance on our patient specimens at 95% meet our acceptance criteria, so acceptable there. If we look at our correlation coefficient, also meets acceptable criteria there. When we look at our slope, we see that it is just slightly outside of our acceptance criteria. So technically, it does not meet our acceptance criteria. However, in this case, honestly, not a whole lot of investigation was done. Because the slope was only just slightly outside of our criteria, we saw good concordance. We ended up accepting this lot because we felt that that small slope deviation did not materially impact clinical performance, and felt very confident that this lot would not show a shift or change in clinical or analytical performance. So let's move on to our third example. Again, this is a different antigen-specific autoantibody, but still by enzyme immunoassay. We'll look at our blank and how it performs on the new lot, meets the acceptance criteria, no problem. The standard also on the new lot met acceptance criteria, so we're good there. If we look at the kit positive control, the value on the new lot falls within the acceptable range established by the manufacturer, so meets that criteria. Kit negative, same thing, meets the manufacturer's what's in the package insert, so it meets our acceptance criteria. And the in-house control, comparing between the current lot and the new lot, very consistent results. Percent CV, about 1%, certainly meets our acceptance criteria. So far, so good on this lot evaluation. When we move to the patient sample comparison on this lot, this is where we started to see some issues. And if you, again, are just kind of looking at that eyeball of red to red, green to green alignment, you're going to start to see that this lot evaluation is not lining up from a qualitative concordance perspective as we saw on the first two lots. When we look at the linear regression, we see something very similar. We see a slope deviation. We also see that our correlation is not as tight as we had seen on the other previous two examples of lot evaluations. So what does that mean here then when we put this all together? Well, for concordance, we did not meet our criteria, so that was a no. Our slope also did not meet the criteria. It was less than 0.8 by a little bit, so that did not meet criteria. And our R-squared also, the correlation between the two did not meet criteria. This particular lot-to-lot evaluation triggered quite a bit of investigation. There was quite a bit of back and forth with the manufacturer. We did expanded sample sets. I mean, a lot of things to investigate this. In the end, we ended up having to reject this lot. We just could not feel comfortable implementing it in the laboratory. We felt that there was what could be a significant impact to the clinical performance of the testing, and ended up not accepting this lot. So that does bring us to a kind of thinking about what happens when you have a lot-to-lot failure, and how do you investigate that? And this is challenging. Investigating lot-to-lot failures is not something that is easy to do. And really it's because each situation is going to be unique. The analyte that you're looking at, the methodology that you're using, all of that kind of plays into how you might approach investigating it. But I think there's a few general things that you can think about when you're looking at a lot-to-lot failure. First of all, I think it's important to consider not only that you have a problem with a new lot, but maybe there's an issue with your current lot as well, right? So the one way we look at this, because we do repeat our sample set on the current lot, it's possible that there was a problem with that particular run for some reason. So we often will go back and pull the clinically reported result that would have been for each individual sample to understand, is the current lot data that we generated as part of the lot evaluation, is that consistent with what was reported clinically? If not, then maybe the issue was the current lot, and maybe that clinically reported result actually compares better to the new lot evaluation. So that's one possibility. The other thing you have to consider is that there could have been a shift in the performance of the current lot over time. Perhaps when you implemented it, it had one kind of performance characteristic, but something has happened over time, some kind of reagent instability, something may have happened that has impacted that current lot performance. And perhaps that is why you're not seeing as good a correlation with a new lot because of that issue with the current lot. So that's something that could be considered. It's also important to think about the nature of the discrepancies that you're seeing. How would you characterize those? And sometimes it helps if we think about where we're seeing a lot of discrepancies between the current lot and the new lot, we may actually go back and get an expanded sample set. So for example, if we see that maybe 4 or 5 for our negative samples, if we have 4 or 5 negative samples on the current lot and maybe 2 of them have flipped to weak positive on the new lot, we may go back and say, well, we want to look at an expanded sample set, and we're going to enrich that sample set for negative samples, because you really want to know what is happening in that particular performance area for the kit. So that's something to consider too, is targeting a larger sample set to understand the discrepancies that you might be seeing. And then think about potential mechanisms. What could be happening to cause this lot-to-lot change? And the one thing that we often look at is the calibrators. Is there a change in how the calibration looks? Is there a large change in the raw signal from the calibrators that could be impacting the new lot versus the current lot, in the sense that the calibration has shifted a bit. So that's also something to consider. But again, this is all something that every time you have a lot-to-lot failure, you really have to look and see what is failing on that lot-to-lot and how you may go about investigating it. And I also would encourage you, we many often, almost always, will reach out to the manufacturer with questions and guidance to help us understand where some of these discrepancies could be, how they could be arising. So, engaging with the manufacturer for a kit-based test is going to be something I think that would provide a lot of useful information. So that brings us to the end of the webinar. Just to kind of summarize just a little bit. I hope that I've convinced you that lot evaluations are critical for maintaining consistent performance for our autoantibody serology testing. There are certain regulatory requirements that we have to meet. However, we also understand that these regulatory requirements tend to be thinking in terms of qualitative and quantitative methods and not necessarily semi-quantitative methods. The published guidelines also contain very valuable information. However, again, living in that autoantibody serology testing world, these guidelines are not always applicable. But I still think there's important information that we can gather from those guidelines. And you have to think about how you're going to develop a protocol specific to your laboratory, to the analyte of interest, as well as the methodology. Always consider what your laboratory resources are and what you have at your disposal for these lot evaluations. What are the really critical parameters that you feel are necessary for helping you understand the performance of the new lot? And what are the acceptable criteria that allow you to detect a truly impactful change in lot performance without being too stringent in the criteria that you are using? I certainly want to acknowledge the folks that I work with on a daily basis because they truly are just amazing individuals. So I'm in the Antibody Immunology Laboratory at the Mayo Clinic. We have an amazing group of laboratory assistants, our clinical lab technologists, our specialist group, including our technical specialists, quality specialists, education specialists, and certainly a great supervisor and assistant supervisor. I'm so lucky to be able to work with these individuals every day. And then I'd also like to acknowledge my laboratory co-directors, Drs. Ann Thibault, Pat Vanderboom, Maria Wilrich, and David Murray. They are a great resource for me, and I learn something new from them every day, and certainly a joy to work with them as well. And thank you again for listening to this webinar and participating, and I hope to answer any questions that you might have. So thank you again.
Thank you, Dr. Snyder, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located in the lower left corner of your screen, and we'll answer as many of your questions as we have time for. Let's go ahead and get started. Our first question says, I see here that when you use patient samples, you're using the same collection criteria, etc. As if you were to be releasing a clinical result. However, if you are using proficiency testing samples, how do you suggest managing if the material is expired or not?
Yeah, so I think you're referring when we collect those patient samples for the lot-to-lot evaluation, we're collecting from our clinically reported results. And I may have given the impression that we're always picking samples that have kind of just been recently tested, but there are certainly situations where we may have, autoantibodies where we don't get positive samples very often. And for those types of assays, we will stockpile those positive samples in our freezer and then use them for lot-to-lots. So there may be occasions where even the patient samples that we're comparing on may actually be expired according to kind of our stability that we would use for clinically reporting those results. But we still use them for lot-to-lot evaluations because we do retest on the current lot. And so we're not so much concerned with whether or not there's been degradation or something like that happening, as long as the as long as at that point in time when we test the sample, the current lot and the new lot we're evaluating compare. So I think that kind of relates to what you're asking here, because I would apply the same criteria to a proficiency testing sample. If you're going to use a PT sample as part of your lot-to-lot evaluation, even if it would be technically expired, if you're retesting on the current lot along with your new lot and looking at it at that point in time, I think you'd be okay. In my opinion, that's acceptable to do.
Excellent, thank you. Our next question asks, if there is not a positive sample for the testing, would it be useful to use the control but with dilutions using a negative specimen to check the cutoff?
Yeah, I'm glad this question came in, because it's a really it's a great idea, and sometimes we will do this occasionally as well. Taking a calibrator or a QC material, either manufactured or purchased from from a vendor, and spiking that into a negative patient matrix, a pool, and a negative serum, whatever it might be. I think it's a good idea because you kind of get that matrix that we're hoping to kind of control for with patient samples, and it might give you an additional positive specimen or two that you can use for a lot evaluation. So, and there have been times that we have done this as well in lot evaluations and in other scenarios. So I think it's a reasonable idea, definitely.
Wonderful, thank you. Our next question here says, we have gotten pushback from manufacturers when the kit controls of an FDA-cleared qualitative test, interpreted from a binding or fluorescent signal threshold, are in range, but our internal lot-to-lot evaluation suggests a significant change in the fluorescent binding signal greater than 25% CV. What is the best way to handle this?
Yeah, it is a challenge for sure, because I think, the criteria that a manufacturer might use for evaluating a kit may not be the same criteria that we are looking at in the clinical laboratory. I also think that when we're looking at sample, in the clinical laboratory, we often focus a lot on looking at patient samples, and the manufacturers may not have the breadth of samples that we do, maybe looking at it more of a limited sample set. And we have definitely seen this. We've definitely seen where all of the manufacturers' controls look good, but then when we start to evaluate patient samples, we're starting to see something significantly different. Um, and this is, where I think engaging with the manufacturers is so important, because providing them the perspective that we have on in terms of how we're looking at these lot evaluations and understanding the clinical impact, also explaining, how our clinicians are using the testing, how they're interpreting the results, and why you're seeing these changes from one lot to the next is concerning, in the sense that it impacts clinical utility. So I'm not sure I have a really solid answer here, because it is challenging, and but I think more and more getting interacting with the manufacturers and making sure they're understanding our perspective from the laboratory will also, it just helps kind of understanding that we're both, we kind of speak different languages sometimes, but making sure that we're kind of at least understanding what the other is evaluating and understanding the importance of that.
Okay, wonderful. Our next question here asks, how should we manage lot-to-lot evaluations if we can't collect enough positive samples to cover the AMR, and for multiplex if we can't collect positive samples for all analytes?
Yeah, I know for laboratories where you may not have large testing volumes for analytes, where the just the incidence of the disease is very low. It definitely can be challenging. Um, we are pretty lucky here at Mayo, because we do have the volume, and it allows us to collect a fair number of positives. But as I said earlier, even we have challenges with collecting samples, and that's why, for some, as I mentioned, some of the more rare autoantibodies, we do basically never discard a positive sample. We would keep every single one of them, and sometimes we have to go back into our bank and pull samples that may be 6 months, a year old, in order to get enough samples for a lot evaluation. So you may want to consider doing that. I mean, I think the issue is the same on the multiplex assays, right? It's just a matter of, are you able to find positive samples? There are other options. Maybe we have often sometimes and reached out to other laboratories and see if there's an interest in sample sharing, splitting aliquots and sharing samples across labs. Not that you're going to compare to that other laboratory, but maybe just be able to expand your reach in terms of acquiring positive samples. I think the example that was that question that was asked earlier about spiking controls or calibrators into patient matrix would be another way that you could generate a positive sample. And, we try to cover the AMR as we can, but I always tell the laboratory, we have the samples that we have available to us, and that's what we're able to use. And there are times when we also aren't able to cover the AMR as much as we would as much as we would like, but we do our best with what's available from the laboratory.
Great, thank you. And we have time for just a couple more questions, so we'll keep moving along here. This next question says, in EIA example number 2, would you update your SOP and expand your slope acceptance criteria for future lots, or treat this as a one-off given the written justification for this new lot?
Yeah, it's a really good question. In this case, I know we did not change our SOP, so I will say that. But it is something that definitely comes up in conversation. And usually, though, before we would make a change to the SOP, rather than looking at just one lot to lot evaluation, oftentimes we will go back over maybe two years, even depends on how many lot to lot evaluations we've done, and really look at, how have the lot to lot evaluations performed on this particular analyte, on this particular platform? Have we routinely been failing lot to lots? In that case, maybe we should look at our acceptance criteria. If we generally pass and this is a one-off, then maybe we don't change our SOP, we just write it up as kind of a deviation and our reason for accepting it. But I think it's important to, I mean, like I said, we before we would make any change to our SOP, we do like to go back and review the lot to lots to kind of understand historically how they have performed. The other thing I will say is that I tend to be more of a fan of keeping our criteria where I think it needs to be, and not necessarily to make sure we're accepting the lots, or to make it easier to accept those new lots. And I think it's important because if we're not meeting a certain criteria that we think that the assay should be performing at, I'd like to know about it. I don't want it masked because our acceptance criteria, we've set it too broad. And I know sometimes that makes more work for the laboratory in terms of having to investigate, but it in my mind, it's so important that you understand the performance of your assays, including the limitations of it. All these assays have limitations. All platforms have limitations. So by having some reasonable criteria set, you'll at least have a good sense of how the assay is performing, rather than setting criteria so broadly that you're just accepting a lot because that's what you're that's what you're trying to do. So that's what I would say for the question, for that answer. Yeah.
Great, thank you. All right, our next question here says, is the strategy of comparison to the existing lot vulnerable to slow drift over time? And if so, how do you protect against this?
Um, Good question. And this is actually, as I was putting the presentation together, this question would have been addressed by a slide that I ended up taking out for time. But you're right, drift over time from one lot to the next, even though one lot to lot's acceptable, the next one's acceptable, the next one's acceptable. Over time, there could be some slow drift, right? So we know that can happen. The one thing that we have been looking at in my laboratory is identifying a sample set that would have enough aliquots for each individual sample that they could be used over multiple lots. So we have some more of that traceability, rather than just looking at each individual lot to lot as a kind of like that, as that single data point, and then you move on. By having this established sample set, we would hopefully be able to have enough volume of these samples to assess performance over 2 or 3 lots. So we would have some traceability there. But going through that process, again, this is pretty resource intensive, and it's been a challenge for us to, collect enough samples, cover the AMR, all those other criteria that we need to, and be able to get enough volume, as I said, to have, that traceability over one lot to the next. It is something we're trying to move to. I think we'll move to it for a few analytes to begin with and see how it goes. But that's one way that we've been thinking about trying to address that particular question. Yes.
Great. All right. And we have another question here that says, what if it turns out that the previous lot is the source of the issue? Would you recommend retesting to the patient samples that were tested using the previous lots and make an amended report?
Yes. So every once in a while, it does turn out that the previous slot is the problem. Now, it depends on what the nature of that is. So we've had occasions where, as I mentioned, we take our sample cohort, we retest it on the current lot and then test on the new lot. Occasionally, it's just that one run on the current lot that is kind of not meeting or not acceptable, that's showing some variation. And when we go back and retest patients that have been tested on previous runs on that assay, they're all acceptable. They repeat perfectly fine. So if that's the situation, then no, we certainly would not go about, um, amending reports or revising the results. However, if our lot-to-lot evaluation shows that our current lot has drifted over time, then we may consider doing it. It just depends on how far back we have samples, how much retesting we can do. Because if we're not able to retest, it becomes more of a challenge because especially for some of those results that may have been out there because sometimes we're in a lot for 6 months or even longer. So it kind of depends on the situation. But yes, I would say that if you identify that the current lot has changed and drifted, and that you're picking that up in your lot-to-lot evaluation, you may consider going back and retesting at least the samples that you have available and possibly revising those results.
Great. All right. We're going to squeeze in just a couple more questions because these are really great questions coming in. This next one says, frequently, if the lab rejects a lot, then they don't have reagents to use. Do you have an alternative method or reagent validated, or do you send the test out?
Usually we end up sending the test out, to be honest with you. And the reason for that is that we know that autoantibody testing is not well standardized from one assay, one manufacturer to the other. So if we were to have a secondary method available to us and validated, just kind of sitting there waiting, what would be required was, well, there'd be probably a reference range change, AMR change. In other words, we would have to rebuild that in our LIS. And we just don't have the capability of having kind of that second assay sitting there built in our LIS to be able to report it. So usually our process is that if we believe it's going to be an extended period of time, we would take the test down, try to find a send out lab that could do the testing for us until we're able to either work with the manufacturer to get a lot in that is acceptable, or to in a situation where we don't feel that's going to be feasible, then we would take that time to bring up a new method, do that validation, get it built in our LIS, and then be able to begin offering it.
Wonderful. Thank you. All right. Our next one says, if an expected positive result comes up as negative on both lots and your sample selection criteria required you to have 8 positives, 4 negatives, would you add an additional expected positive to ensure you meet that initial criteria?
So in our SOP, we try to, can I say it? Those are kind of minimum numbers. So, um, it would depend, I think. If the lot evaluation looked good and we were just off by kind of one sample, probably not. I would probably just accept it and again mark it we would document it as a deviation from the SOP. Sometimes for the SOPs, we do, as I said, have a minimum number. So if we exceed that number, we wouldn't consider it a deviation as well. But, again, if it's just that one sample, I probably would not go back and try to repeat it, especially if it passes our criteria and everything looks acceptable. I think I would just accept it and move on.
Great. Thank you. All right. And we're going to ask just one more question here. I know we're already over on time, but these are, again, such great questions. Our last question here that we have time for during the live is, on occasion, repeat testing of a patient sample may yield a clinically significant change in results. For example, a new pattern is observed for ANA on repeat, or a previously negative or borderline result is now above threshold. Are patient reports revised?
Well, again, it depends a little bit on the situation, but we have certainly come across issues like that, where we might, as part of our lot to lot evaluation, might identify a change in a patient result. And if we, in discussion, sometimes with the clinician, sometimes among the laboratory directors, if we would deem that that is a clinically relevant change, then yes, we would make a revision to the patient result.
Wonderful. Thank you, Dr. Snyder, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Biorad Laboratories, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.